It's great to be here in New Haven on a rainy, cold day. And I don't get up here that often, but I have a lot of friends, and a number of them are in the audience today that have become friends. We started out as colleagues, and we're actually friends now, so that's always good. And as Robert said, I am going to talk about my view of the data that supports the notion that drug abuse treatment is an HIV prevention intervention, and some of the limitations of how that's played out in the world today, and some thoughts on future directions and future research that's needed. So the basic points I want to make is I first want to set the stage epidemiologically and just remind everyone of what we know about the epidemic of HIV that's driven by injection drug use. Most of the data is focused on injection drug use, even though probably most of the infections are related to non-injection drug use and drug abuse. I won't talk much specifically about hepatitis C, but I want everyone to be thinking in terms of HIV/hepatitis C. These are infections that are transmitted through the same behavioral mechanisms. Hepatitis C is transmitted less through sexual transmission than HIV, but definitely is easily spread through the use of contaminated injection equipment. So I want to make sure that's a prominent theme in this talk as well. The data that I'll present really is going to be a summary of data that comes primarily from methadone treatment. I'll present this as a proof of concept, basically, that effective drug treatments can reduce HIV infection and, to a certain extent, hepatitis C infection. But I don't want us to restrict our thinking to methadone treatment, even though that's where the past 20 years worth of data has primarily been focused. We still, despite lots of evidence, I think can say that we have minimal treatment coverage in the United States, but more prominently in the rest of the world. We just don't have enough access to treatment to meet the demand and certainly not the need. And so we have to think about ways to take the knowledge that we've gained and expand options for people to receive treatments for substance abuse. And I'll talk a little bit about that. And finally, making the point that we'll be much more effective in our efforts if we view drug treatment not as sufficient, but as necessary component of a public health model that includes a number of interventions and programs that we know reduce the spread of HIV infection among drug users. So those are 5 points. I have about 40 slides to make 5 points, so just bear with me. And basically, most of you are probably familiar with the basic epidemiology of AIDS and HIV infection related to injection drug use. Probably about 33 million people currently infected with HIV. Approximately 10 million infections can be or have been attributed to injection drug use. Outside of sub-Saharan Africa, we project that about a third of all new infections are related to injection drug use. Even though we're changing our perception of Africa, there's a lot more recognition now of the prevalence of drug use and its role in the spread of HIV. and including injection drug use. But perhaps most importantly, we don't have many good estimates of the major role of alcohol and non-injection drugs in the global epidemic. And wherever we look, we find pretty substantial roles for these substances in the transmission of HIV infection. I just want to make that point a little more clear with some data from the EXPLORE project, which followed about 4,000 non-injecting men who have sex with men. It tested an intervention that proved not to be efficacious. It was about a 12-session intervention using counseling strategies with the men to reduce HIV risk behaviors. When the study was finished, however, there were about 300 HIV infections in this group of 4,000 individuals, and when analyses were done to predict or to look at the predictors of HIV infection, there were the strongest predictors were actually substance use related. So these are sexual transmissions, not injection-related transmissions. The hazard ratio of 1.87 for heavy alcohol use, 1.93 for amphetamine use, that accounted for 67 infections among the 527 people who reported using amphetamines. And for those who reported using alcohol or drugs prior to sexual activity, a hazard ratio of 1.57. I'm using this data because it's the largest study of non-injection drug users and predictors of HIV infection that we have so far. And I think it reminds all of us that we need to pay much more attention to developing effective treatments for non-injection drug use, particularly in high-risk populations like men who have sex with men. Now, historically, prevention strategies for drug-using populations have included first education, HIV counseling and testing, increased access to sterile injection resources and condoms, drug treatment, and more recently, HIV treatment are considered effective strategies for reducing risk behaviors and infections among drug-using populations. I'm going to be talking primarily about drug treatment, but I'm going to return to this point at the end and saying that all of these strategies need to be present if we're talking about protecting communities from the spread of HIV infection. It's also important for you to understand my view, or at least my understanding of addiction as we start this discussion. Addiction is a medical condition. It's a treatable but a chronic medical condition. There are important biological components that some of our medications that we've developed can help to address. There are behavioral components that need equal attention in treatment as well, and I would say that we've kind of minimized the importance of these behavioral interventions, particularly drug-related counseling, in conjunction with the use of medications. And we're not really talking about cures for addiction, we talk about effective management. Like other chronic medical conditions, there is a requirement for ongoing interaction with health professionals. Now, there are a number of factors that influence how we think about drug treatment in our ability, or in the ability of drug treatment to actually have an impact on the epidemic. Some of these factors include the prevalence of drug use in a particular area. That's going to have an impact on how we design and deliver treatments, the mode of administration, the types of drugs and the drug combinations that are being used by individuals in communities. Co-occurring infections and political forces are all going to have an impact on the kind of drug treatments that are not only possible but important to be able to deliver. The CDC estimates we have about 100,000 adults in the United States. This was in 2007. That are living with living with AIDS diagnoses. This is just a map. I like maps. I think it reminds us that, first of all, the epidemic is not randomly distributed geographically, and we have tremendous variation in prevalence rates and risk of infection as well. Now, this is related to injection drug use, and obviously the East Coast, and particularly the Northeast, is more heavily impacted by injection drug use. And again, that's going to have an impact on the kind of treatment systems and treatment approaches that are developed. Also, the mixture of drugs. This is the WHO's estimates of the types of drugs that are being used and are leading people into treatment around the world. These pie charts just show a distribution of the number of people entering treatment and their primary drug of abuse. The green represents cocaine, and the gray area is stimulants. The brownish color is are opiates, heroin primarily, and the yellow is marijuana. As you can see, I mean, in the United States, even though stimulants might be the predominant reason for entering treatment, there's a variety of drugs available and being used, and that's increasingly the pattern that that we're seeing. But despite the fact that addiction is a medical problem, these variations require different strategies for treatment, and as does the mode of administration. This just is an estimate of the prevalence of injection drug use globally, with the darker shaded areas higher prevalence. As you can see, in no country is the estimate much higher than 1%. Despite that factor, we have a number of countries where the majority of HIV infections are attributable to injection drug use. So this is, I'm sure, you know, for those of you're all, or most of you are students in public health and probably have already learned this, but it seems to me that this data clearly makes the point that when we neglect the health of even a small slice of the population, it can have huge impacts on the overall health of the overall public health and the health of communities. I've been working more recently in Asia, in China and Indonesia, where the epidemics are still strongly being driven by injection drug use. In China, it's restricted to certain provinces. In Indonesia, it seems to be still the primary risk group that's driving the epidemic is in injection drug use. Malaysia and Vietnam have similar patterns as well. So there are still regions of the world where injection drug use is the predominant mode of transmission. We're doing a study in Jakarta right now where we're looking at the impact of adding counseling to people coming into methadone treatment programs. And in the program already, 70% of the patients are infected with HIV. So these are patients in methadone treatment who are already infected with HIV. And 70% of the patients who have HIV infection are also infected with tuberculosis. So there are huge treatment issues and unique challenges in these regions of the world. This is data from, except for the Philadelphia bar charts here, this is data from a relatively small study, but it's interesting because they introduced, this was a WHO project that introduced methadone treatment or buprenorphine treatment in China, Indonesia, Thailand, Iran, Lithuania, and Poland. The red bars represent the prevalence of HIV infection of people coming into the treatment programs. Again, this is China, Indonesia, Thailand, Iran, Lithuania. Sorry, you can't read the bottom there, Poland. And this is Philadelphia, by the way. But that was to make another point for another talk. But the green charts represent hepatitis C. And so an obvious finding and an important point is that in the same communities where we see even low prevalence of HIV infection in the same populations, we see almost universally very high prevalence of hepatitis C. Again, this is a virus that we have not yet come to grips with in terms of effective preventions. We're developing many more effective treatments now. It looks like we're going to have protease inhibitors and similar kinds of treatment approaches for hepatitis C. But right now, there's not much work being done to prepare for the treatment of drug users with these new medications. So I think there's a real research and treatment opportunity with the new medications for hepatitis C. I mentioned earlier that politics always has an impact on not only the availability of drugs, the distribution of drugs, but it also has an impact on what treatments are acceptable and what approaches are going to get the most public support. This is at a border crossing between Vietnam and Laos, and basically it's a sign that you can find in some form at almost every border crossing in the world, which says if you're caught with drugs, there'll be severe consequences. Some countries it's more severe than other countries, but there are still consequences, and it's generally not a good idea to get caught with drugs. But the strategy that is universal and still receives the most funding to address the drug problem in the world are criminal justice approaches. Probably the next most common is detoxification approaches in one form or another. This is from the largest detoxification center in China. It's in Wuhan, China. We were doing a study 10 years ago in Wuhan, and we were offered the 1,000 residents of the detoxification center as subjects in the future studies. But China has made some amazing progress in the development of treatment programs, and I don't want that to be the last word that I say about China. In fact, I have some slides later on to talk about that. But the point I want to make is that globally, governments have invested very heavily in detoxification approaches that just don't work. they're time limited, they basically remove people from the community, they detoxify them for sure, but there's no treatment, there's no evidence that this approach has sustained treatment when people leave these programs. Relapse rates from detoxification alone are over 90% within 3 months of the end of the treatment. I'm going to just show you very briefly some data that's almost 20 years old now. It gets shown a lot by a lot of people, and it's my data, so that's why I'm showing it. And it was, but I think one of the reasons it actually gets presented often is because it's one of the few prospective studies we have on drug users and HIV infection who are both in methadone treatment. These bars here show the prevalence rates of HIV infection in Philadelphia among our 255 drug users. Half of them were in methadone treatment and enrolled and followed for 6 years. And the infection rates went from 13 to 21%. And for those who were recruited from the same neighborhood and were out of treatment and followed for the same amount of time, we had, by the way, over an 80% retention rate for this whole period, although 40% of the participants died during the course of the study. The prevalence rates were higher at baseline and showed a much higher rate of new infections. So people at NIDA love this slide, you know, and even this summer, you know, it was shown in making the point that drug treatment prevents HIV infection. The story is a lot more complicated than that, but we've actually made a very good sales pitch using this data, and we've convinced lots of people that methadone treatment is HIV infection, and it's, I think, had a positive effect of spreading the notion of drug treatment as an HIV prevention intervention. We've not been as successful at making the point that addiction treatment is HIV prevention, and so that's resulted in I think a simplistic view of HIV prevention by establishing systems that are good at distributing medications, particularly methadone. Again, I'll talk more about that in a minute. We also have some data from other studies, of course, other than the study that I did or was involved in, but not much data on hepatitis B prevention or hepatitis C prevention that actually measured the incidence of these infections. And again, what we see is this is a study that was done in Seattle by Hannah Thied and Holly Hagen, looking at people who entered treatment, looking at them 12 months later. And the red bars represent the people who left treatment, and those individuals had the highest incidence rate for hepatitis B and hepatitis C. For the people who were in treatment part of the time, we see a somewhat lower rate, and the lowest rates of infections for both hepatitis B and hepatitis C were among people who were in methadone treatment and stayed in treatment for the 12 months. So we have lots of data now collected over the past 25 years that suggests, first of all, that effective treatments recognize addiction as a chronic disease. They use pharmacologic interventions as well as counseling interventions, and are accessible, acceptable, and affordable. So how does How, what is the mechanism of action of treatment? How does treatment prevent people from getting infected? I think it's actually a rather simple model. When drug treatments are effective, people reduce the frequency of drug use. The lower frequency of drug use results in fewer drug-related risk behaviors and fewer infections. We also, importantly, have data now, a growing amount of data to show that people in drug treatment programs have increased access to HIV care if they're already infected with HIV, as well as to primary health care, and that those who are in treatment and in HIV care have greater adherence to their HIV medications. And all of these things contribute to reductions in the transmission of HIV. Importantly, there was a study done recently, and I say importantly because it's not simply a matter of entering a treatment program. The treatment has to be effective in reducing drug use. And what this study, which was done in France, it looked at drug users who are in both buprenorphine treatment and methadone maintenance treatment. And these bars here are people who were in treatment and were not continuing to inject. And their adherence rates were equivalent to those who were abstinent or people who were not never used drugs. So being in treatment is important, but it's not as important as stopping your use of drugs. And there are, as many of you know, many people who are in treatment programs but continue to use drugs. It's really the drug use that interferes with these other behaviors. Those who were in buprenorphine treatment and methadone treatment and who continued to inject were twice as likely to be non-adherent to their medication and much more similar to those who were drug dependent but not in treatment at all and continued to inject. So it's not a matter of just entering treatment that reduces risk or improves adherence. It's actually responding to the treatment. So basically, we have these data from the past 25 years that are all very positive findings. And the question that I think is important for us to consider at this point in the epidemic is, have they had an impact? Have these data had an impact? And I would say that we can say, yeah. There are limited places, or there are examples in the world where we can show that these data have propelled the expansion primarily of methadone treatment. In these places, I would say also that, as I mentioned earlier, that most of these treatments are promoted as harm reduction strategies, where the goal is to get people on methadone and keep them on methadone, but there's very little attention paid to the addiction treatment, which requires some attention to counseling and the individual's motivation and intentions to stop using drugs. I would say it's had little effect on reducing interventions designed to reduce non-injection drug use and its relationship to HIV risk behaviors as well as stimulant use. We still don't have much in the way of effective treatments for stimulants. We don't have much emphasis on reducing risk for hepatitis C or expanding treatments for hepatitis C. Probably the best example of where this data has had an impact is China. They've gone from 0 methadone programs in 2004 to over 600 methadone clinics today. This is a couple years old. And I believe there are about 200,000 patients on methadone treatment. It's the largest treatment system really in the history of the world. And it's been developed most rapidly. And I think it's really a monumental achievement, and one that that China should be very proud of, that we should all be proud of. Unfortunately, the treatment system, as I mentioned, has not been focused, in my opinion, sufficiently enough on treating addiction, but on distributing methadone. But it's, you know, it's new, and there are a number of people in China that are interested in improving the efficacy of methadone treatment. NIDA's involved. I'll talk about a study that we're currently doing with Suboxone in China. Richard Schadenfeld and Marek Jaworski are doing a study now in Wuhan, China, in the methadone treatments, trying to evaluate the impact of the counseling program there. So there are great developments. There are questions, research questions that we can not ask in other places because of the scale of the program that we see in China and the stage of development. And we're starting to see some of the same patterns of findings in terms of the impact. And again, this was done in Sichuan, China, by Hanzu Quan. And it shows the rate of needle sharing among injectors who have no history of methadone treatment compared to those with a past history and those who are currently in treatment. And again, we're seeing obviously the same pattern of risk behaviors. And so one of the important things that we're able to do with this kind of data is when we set it next to data from other settings around the world, we can start developing I think models for our expected rate of risk reduction for people involved in methadone treatment. Even though the rate of needle sharing may vary from these places, the impact of the treatment may actually be quite similar. There's obviously a clear need for more treatment options. This is from a recent article by Mathers and the WHO group, and it just, you know, the red here represents countries that don't have any medication-assisted treatments for opiate dependence. And it's obviously a significant issue for Russia, which has a huge epidemic among opiate injectors and policies that prohibit the use of methadone or Suboxone or other agonist treatments. The other shades represent various, just the presence of clinics that treat using methadone and Suboxone or both. The actual level of coverage is quite variable, as you can imagine. Australia, Europe, United States, Canada tend to have among the higher rates globally. But the rest of the world has rates that are less than, well, if they have treatment at all, is less than 2 or 3% of the injectors have access to these treatments that we know can be effective. So there's just a huge scale up that's required if we're going to provide adequate coverage. And my own opinion is that we can only do so much with Suboxone and with methadone, and we have to necessarily think of new strategies, new treatment approaches, and new mechanisms for delivering treatments that we know are effective. So one of the more recent, although it's almost 10 years since its approval, was approved in 2002, but buprenorphine, naloxone, Suboxone. There are people in the room here who have devoted their careers to studying the impact and models for delivery of this, David and Rick. But it actually has some advantages over methadone that I think make it a very appealing medication. It's a partial agonist. I won't go into the details of that right now, but there is a reduced risk of overdose relative to methadone, less severe withdrawal, and fewer interactions, importantly, with antiretroviral medications. We're currently doing a study that I'm the protocol chair of in Thailand and China. We have about half of our subjects enrolled now. There's 800 subjects enrolled. We're targeting about 1,500 subjects, and we're recruiting opiate injectors from the community and referring them to two approaches to Suboxone treatment. One is short-term Suboxone, which involves the opportunity for two detoxifications, but everybody gets a 1 year of counseling, and of course referral to local treatment resources if those are necessary, versus a full year of Suboxone treatment. Everybody begins the study with a counselor who tells them, look, we've got a year together to work on your drug problem. Let's take advantage of this time. Now, that's actually a unique feature of this study, a 1 year treatment approach. It's controversial to some, but it's actually based on evidence that a minimum of 1 year treatment is necessary in order to see an impact on infection rates in a community. And also it's based on the fact that most people, when they're offered access to methadone treatment or Suboxone treatment, don't stay in treatment for nearly this long. So I think it has some public health relevance. If we can show that these treatments have sustainable impact, and we'll be following folks for 2 years. So a year after treatment, we'll be following individuals. Now, it's powered based upon incidence of HIV infection. That's a requirement for the HIV Prevention Trials Network. We're not seeing enough infections to answer the primary study question at this point. So we're already gearing up for answering our secondary questions, which will take a look at continued injection and reductions in risky behaviors. But again, this is when I said earlier that we need to start developing and testing new models of treatment. This is the kind of thinking that I think, well, certainly that I was referring to, but I think we need to develop new strategies and new ways of thinking about delivering treatment other than saying you're a drug addict and you're going to need to be in treatment for the rest of your life. Although some people do need that. We have to be much more selective and much more specific in the way we design and deliver treatments. In the JAKPRO study that I mentioned earlier, we're working with five methadone clinics in the city of Jakarta and randomly assigning individuals to methadone treatment as usual, plus the behavioral drug and risk counseling that was developed by Marek Jaworski and Richard Schadenfeld, and first, I guess, tested in Malaysia. But it has some basic common elements of cognitive behavioral approaches to therapy. These kinds of treatments are focused on current issues in an individual's life. Short-term goals are established. This is not psychotherapy. This is not talking about the origins of a problem of drug addiction, but it's talking about how are you going to get through tomorrow? How are you going to get back here for your medication next week or tomorrow? So it's setting short-term goals, very practical, things that individuals without advanced degrees can be trained on and trained to deliver in a pretty effective way. So we're randomly assigning people to treatment as usual, which allows individuals who are having problems to say, I'd like to talk to somebody about my problem, but it does not establish a structure to the counseling. So it's basically, I would say, counseling on demand, and when counseling is delivered in these situations, it's quite variable. It depends on who you ask and which physician or which nurse ends up talking to you as to what kind of counseling you're going to get. And quite honestly, physicians, nurses, and most professionals working in the field aren't trained on how to talk to drug users in a way that moves them in a positive direction. And that's really what we're talking about with these structured counseling approaches, simple ways to help people talk to drug users in a way that helps them understand what's going on, first of all, and then helps them make decisions that are positive decisions. Most people's instinct, who are not trained in these kinds of approaches, are, involve some form of guilt and shame and drug users, that's the one thing they have a lot of, is guilt and shame already. And by embarrassing people or making them feel more guilty will only drive them further away. So anyway, I think we've underestimated the importance of counseling, and as a consequence, we haven't trained people in the field well enough on how to do productive and positive counseling. So that's the theory underlying this study, and we'll follow people for a year and do behavioral and HIV tests as well. This is a study that Marek and Richard have just, I believe it's in press if it's not already published. But this is a pilot study done in Wuhan that had a similar kind of strategy, standard methadone treatment versus methadone treatment plus BDRC in 2 clinics in Wuhan. And the illicit opiate use was significantly lower at the end of the study among the individuals who received the methadone treatment and the BDRC. And the same this is a reduction in risk behavior was more prominent. It was significant as well in the BDRC group. This is, as I mentioned earlier, based upon counseling model that was first used in the Malaysia study. And this study compared buprenorphine and naltrexone both to a placebo group. All groups showed reductions in risk behavior. The importance of this study, I think, is also that it's not just methadone, it's not just buprenorphine, but it involves naltrexone comparisons. Naltrexone is an opiate antagonist. It's been around for many years, but not widely used because patients don't want to take their medication. It blocks the effects of opiates. You don't become dependent on the medication, so you can stop taking it at any time you want to. So in what we've seen in the studies, at least that I've been most closely involved in, people genuinely want to stop their heroin use. And they generally like the idea at one point in time that if I take this pill, I won't be able to get dependent on heroin again. I won't feel the effects of heroin if I take it. But like I said, after about a week, people start thinking, boy, the heroin, it wasn't all bad. There were some moments of pleasure, I don't have those moments of pleasure anymore. And after 2 weeks, they say, well, I think maybe I just won't take my naltrexone today or tomorrow and try some and go back to some of those old behavior patterns that are comfortable and familiar and sometimes reinforcing. So in our setting in the United States, we've had almost no success except in situations where there's a lot of social and legal pressure on individuals. We've seen some success with guys on probation, and we've seen some success with physicians who might lose their licenses if they continue or relapse to heroin use. But as a general rule, it's had no widespread applicability to the population of heroin users, and particularly heroin users who are at high risk of HIV infection. So, and this was a study done in Russia by George Woody and the group at the Pavlov Institute, which compared naltrexone to placebos and naltrexone with fluoxetine. Basically, the naltrexone was the active ingredient, and there was a significantly longer retention in treatment among the individuals who got the naltrexone. So now, I mentioned earlier, in Russia you're not allowed to use methadone, so there really aren't many treatment options in terms of medication-assisted treatment. So we saw some effect there, but it's also the concept of this medication is appealing to many people, and I think lots of people have been saying for a long time, wouldn't it be nice if people didn't have to take it every day? And so now through the development of a naltrexone implant, and we now have Vivitrol, a long-acting injection. With just one implant, you can be protected for, I think this is actually for 3 months. The implant is delivered through a syringe, basically, in the abdomen. And it's called Prodetoxone. It's a Russian product, and you don't have to take it every day. And so it actually opens up some opportunities for new strategies for treatment, new individuals, or some slice of the population might be quite interested in this. So that's the implantable. There was a study done actually comparing oral naltrexone. Again, the Pavlov group did this. Oral naltrexone to the implant. This was the red line is the implant. The oral naltrexone is the green line, and the purple line is the placebo arm. So yeah, if you implant a medication in people that blocks the effects of heroin, they're going to use less heroin. But interestingly, it's not like 100%, and there are some variations across the time frame. So we see significant improvements in terms of adherence related to the implants. There's also, this concept of long-acting medications. We're now starting to see the early tests of buprenorphine, long-acting buprenorphine. And again, these are retention rates in a 6-month trial. There were the retention rate for the buprenorphine, and it's compared to a placebo, by the way. Placebo injection. Yeah, it's kind of an odd comparison since we have oral buprenorphine, but this is the way many medications are first tested. So about twice the rate of retention with these long-acting medications. Vivitrol, which is the injectable naltrexone. lasts for 30 days. Obviously, we see 50% of the participants had 90% of their weeks opiate-free if they got the injectable naltrexone. The placebo group had 35%. So people without any active medication, 35% of them did, they had 35% of their weeks opiate-free. Obviously significant differences. So these long-acting medications are of interest. They need to be considered in terms of future trials and designing future trials for HIV risk reduction. They may have some significant cost advantages, although the medications and the implants themselves are quite expensive. In terms of the staff required and to deliver it, it's much less involved than a methadone treatment program or a regular Suboxone treatment program. This is a Swedish study, and I'm only mentioning it because naltrexone was used as a treatment for amphetamine use, and there was a significant effect found in terms of clean urine samples over the course of the 12 weeks. These are 24 urine samples, but done over a 12-week period. So naltrexone medication is being used as is being tested as a prevention for amphetamine use. That's a significant development for HIV prevention, since right now we don't have any effective medication-assisted treatments. There are a lot of limitations to the studies, the treatment studies that I've reviewed. There's measurement variability, treatment delivery variability. Almost all have very short-term follow-up periods. Focus has been on opiate-dependent injectors, very little on stimulant abuse, and no randomized trials for treatment with HIV or HCV endpoints. I'm going to wrap this up now and just make a few points about future research. And I think you've already heard most of my conclusions throughout the talk here. But I think it's very important that we develop ways of delivering treatments with lower intensity, more cost-effective strategies, able to intervene with drug users before they reach the most severe stages of their addiction. There are new strategies being tested that are trying to identify drug users early on and deliver treatments before they reach the stage of drug dependence. And again, we need to make sure that we're considering the treatment costs and the costs of delivering these various treatments, because as a public health intervention, if the treatments that we're testing, the treatments that we're developing and implementing can't be widely disseminated or sustained, there's really not going to be a long-lasting impact on public health.